With that, we are all set to begin. And so I turn over to our director, Dr. Teresa Kasayeva, the director of WHO's Global TB program, to start.
Thank you very much. Dear distinguished colleagues, partners, and friends, I'm Dr. Teresa Kasayeva, Director of the WHO Global Tuberculosis Program, and I'm very pleased to welcome you today to this very important NTB webinar to commemorate together World Children's Day and World Antimicrobial Awareness Week. As we know, World Children's Day marks the day 3 decades ago on which world leaders adopted the historic Convention of the Rights of the Child, promising to every child to promote and protect their rights, including the right to life and the right to health. But we should say now, according to the topic of our event related to TB, that tuberculosis remains the world's
Teresa, you are on mute. Apologies.
So, colleagues, can you hear me now?
Yes, now we can hear you.
So you didn't hear me from the very beginning. Should I repeat?
No, it's just the last sentence.
Just by the end, I guess. Okay. So we now moving to the subject of our event. Tuberculosis, as I told, remains unfortunately the biggest infectious disease killer in the world, and continues to violate children's right to a safe and healthy childhood. In 2019, an estimated 1.2 million children under 15 years of age fell ill with TB. And unfortunately, more than 230,000 children lost their lives to this preventable and curable disease. Of the children who lost their lives to TB, 80% had not even reached their 5th birthday. Any child who dies from TB is one too many. This week also marks World Antimicrobial Resistant Awareness Week. Multi-drug resistant TB is a major contributor to antimicrobial resistance. Children acquire MDR-TB mainly through transmission from close contact with an infectious adult or adolescent with MDR-TB. Researchers have estimated that between 25,000 and 32,000 children develop MDR-TB every year. In September 2018, at the UN General Assembly high-level meeting, first ever on TB, heads of states, ministers, and other leaders committed to provide care by 2022 to at least 3.5 million children with TB and to at least 115,000 children with MDR-TB. According to the 2020 WHO Global TB report, which includes data on MDR-TB in children under 15 years for this time, we can see that progress is falling far short. And you will hear, I'm sure, in the presentations today more details. Globally, we have only reached 8% of the global target of 150,000 in the first 2 years since high-level meeting on TB. For childhood TB overall, we are at 20% of the 5-year target of 3.5 million. This has also been highlighted in the recently released UN Secretary General Progress Report. As we all know, the COVID-19 pandemic further threatens to reverse gains made towards targets and impacts severely on pediatric MDR-TB detection and care. Lockdowns, for instance, led to delays in TB diagnostics and treatment in all age groups and increased household exposure and transmission of TB. There is also indirect impact, for example, through reduced household income, increased poverty, food insecurity and malnutrition, missed health checks and vaccination, amongst others. Today's webinar will focus on how we can make faster progress to reach these targets and overcome the public health crisis of drug-resistant TB in children and adolescents. So this is why I'm very pleased to welcome our distinguished lineup of speakers today. Their powerful voices for the fight to end TB and drug-resistant TB. Our speakers include a young MDR TB survivor, representatives of countries, civil society, partners, and care providers. We plan to have a very interactive format. If you have questions, please post these questions in the Q&A using Q&A function. Our panelists will respond to your questions either online or live during our virtual Q&A and dialogue session. So with this, I'm pleased to start opening session with Dr. Ben Marai, a pediatrician from the University of Sydney, as well as Vice Chair of the Child and Adolescents TB Working Group, who will speak on pediatric MDR TB and the AMR agenda. Ben, please, the floor is yours.
Thank you, Teresa. And good evening from Sydney. I realize it's morning for most people. I hope you can see my screen. So I was asked to talk about the background and give an introduction for why we should focus on childhood MDR. As Teresa has said, important day where we think of both AMR and childhood health. One of the big points that haven't been emphasized in the past, I think, and which has led to an underappreciation of the risk that children are at from MDR TB is that we didn't appreciate the epidemic spread of drug-resistant TB and the risk that this poses. So the first question is, why should we include TB in the AMR agenda? Teresa has already emphasized that TB is the #1 killer on the planet. Although we're all very COVID aware at this point in time, the difference with TB is that it's been with us for a very long time, and it will be with us after COVID is gone. In addition, TB really affects the young and economically active part of the population, unlike COVID. To understand why we need to involve children in the drug-resistant TB agenda, it's important to quickly revise why transmission is at the core of the MDR TB crisis that we have globally. Let me just remind you what TB looks like in the lung. So for those of you who are not clinicians,
Ben, you're frozen. We cannot hear you. Ben, can you hear us? Okay, so everyone, while Ben tries to reconnect, let's, if we can wait just a few seconds. Otherwise, I think we can move to the next speaker and wait for Ben to reconnect.
I think that we can wait just a few seconds. Yes.
Now we can hear you, Ben.
I'm so sorry. I'm not sure why. We do have a lightning storm here, so that may be partly to blame. But let me quickly recap and not to waste time. For those of you who are not familiar with what TB looks like in the lung, TB causes these big cavities in the lung. And within these cavities, there are millions of TB organisms. And you can see how those cavities communicate directly with your airways, leading to the expiration of TB into the air when we cough,
Ben, maybe you can turn off your video when you speak. That may help because you keep
Yes.
getting frozen. Maybe
Right.
just turn off your video and
Yeah.
yeah.
Let me just stop. Sorry. I'll share that again. Does that work?
Yes, it's much better. We can hear you clearly.
All right. So sorry. So I think what is important to understand is that we know that tuberculosis is transmitted by the aerosol route, but for a very long time, there's been a dogma that drug-resistant tuberculosis is not transmitted in the same way. It partly resulted from observations that Middlebrook made back in the 1950s when he showed in the laboratory compromised and they are less likely to be transmitted. That was the interpretation. But even back in the 1950s, you can see that there was a study done by the British MRC that showed that in households where people they received INH treatment, other family members developed drug-resistant TB as well, although they never received TB treatment. So even back in the 1950s, we knew that drug-resistant TB could be transmissible. And we've had more than 70 years of evolution where the most virulent and most transmissible drug-resistant strains have been selected over time. But for some other reason, we still held onto that dogma that drug-resistant TB is not transmissible and it's not an epidemic problem. We believe the problem was that patients were not taking their drugs, which was untrue because children have been the signal all along that drug-resistant TB is transmissible. We know that children represent transmission. Children don't get drug-resistant TB on the whole because they don't take their drugs. They get drug-resistant TB because someone infected them with a drug-resistant organism. And if it's true for children, it's true for other people in the community as well. And we now know that wherever in the world there's been cases of adult MDR TB with MDR TB, showing that transmission is happening in those communities. So this was ignored for a very long time, until about 2006, 2008, when there was this XDR outbreak that was documented in KwaZulu-Natal in South Africa, where more than 60 people developed XDR, extremely drug-resistant tuberculosis, and they were all infected in this hospital environment, rural hospital environment. All the cases were HIV infected at that time. And when the report was made public, there was a crisis meeting called in Beijing. But the overall conclusion was that drug-resistant TB was transmitted in this instance, but it was transmitted among HIV infected individuals. And there was the assumption that the transmission happened because people were immunocompromised and therefore the transmission was facilitated. There was also an understanding that this may be a very virulent strain that was spreading in KwaZulu-Natal. But studies in other parts of South Africa showed that in different parts of the country, different strains are associated with drug-resistant TB and its spread. So it clearly was not the strain. It was affecting people with and without HIV. So we know it wasn't HIV that was the explanation. The reality is that transmission was happening all around the world, but under the radar screen, because we were still diagnosing TB with smear microscopy, and we didn't know whether patients had drug-resistant TB or not. So you are very familiar with the MDR epidemic in Eastern Europe, also in the subcontinent, but also in East Asia, where we've got some of the highest concentrations of people. Do we see the spread of MDR TB? And I'm just quickly showing you a slide from Mongolia to illustrate how MDR all the MDR detected in Mongolia over this 7-year period. And you can see in the summary slide at the bottom that the provinces that are worst affected in Mongolia are essentially situated all along the Trans-Siberian Railway line. And this northeast Donot province is where there's a blind ending part of the Trans-Siberian Railway line connecting with Northeast China and Siberia. So one example of MDR-TB on the move. Another where we've documented a major outbreak of tuberculosis on a small called Daru Island in the western province of Papua New Guinea. Initial strain typing showed that all these MDR cases had a very similar strain. You can see that big green cluster shows us that all those patients had the same bug. So they clearly got the infection from each other. And you don't have to see this in detail, but if you do the detailed whole genome sequencing, what it demonstrated was that MDR-TB have evolved in Papua New Guinea back in the 1960s, 70s, and that this strain has been acquiring additional drug resistance and spreading quietly within the community for more than 5 decades. Before it was detected in 2010, 2011, it was only detected after expert became the diagnostic test of choice. And I hope those illustrations from around the world will demonstrate to you that MDR-TB is being transmitted wherever there are communities affected by tuberculosis. Wherever there's transmission, we will get children that are affected. So we know that not only TB is the number one infectious disease killer on the planet, we know it should be part of the AMR agenda because it's one of the diseases, the AMR diseases killing most people on the planet every year, and where people have very poor access to diagnosis and treatment.
Ben, we've lost you again. Are you connected?
I'm done.
Okay. Okay.
Thank you. I'm sorry for any interruptions.
Yes, Ben, thank you very much. So you see, we have some challenges with these connection issues, but still we are all together here, and it's important. And thank you for your very comprehensive and nice overview. And we see that it's a really big problem, and we should keep people informed about the transmission, that it's everywhere, and that it's extremely risky for the children, MDR-TB, and this knowledge sharing is absolutely essential. And I think that we should continue with this webinar and other ways of sharing this knowledge. Thank you, Ben. Now I would like to give floor to my colleague, Sabine Verkuhl from Global TB Program. And she will give you more details about our current situation for TB, for children and adolescents with TB, according to our latest data reports, and where we are with the progress and what are the main challenges for now. Sabine, please, floor is yours.
Thank you very much, Teresa. Let's see if I can open. I hope you can see the slides.
Yes.
Great, thanks very much. So my name is Sabine Verkuhl. I'm working as a medical officer in the Global TB Program, specifically working on ending TB in children and adolescents. This slide provides an overview of my presentation. I will start by providing a short overview of data on child and adolescent TB, including in this year's Global TB report, and then focusing on data on drug-resistant TB in children. I'll then be looking at the cascade of care for drug-resistant TB in children, and end with reviewing progress against the targets of the United Nations General Assembly High-Level Meeting on TB. So to start with the Global TB Report 2020, in the report we have a number of new data elements on children and adolescents. Firstly, countries with electronic case-based systems were requested to report in more detailed age bands to get a better idea of notifications in the adolescent age group, which are those children and those ages between 10 and 19 years. Countries were also requested to report on initiation of second-line treatment for rifampicin-resistant and multi-drug-resistant TB in children and young adolescents aged below 15 years. And I will provide more details on those data later on. Also included in the report are data on drug-susceptible TB treatment outcomes in this age group. And then we have a box on data collection for children and adolescents included in chapter 5 with more detail on all the different data elements included in the report. So first, let's have a quick look at the global burden estimates for children. These are the infographics from the 2018 roadmap towards ending TB in children and adolescents, updated with the data from the Global TB Report 2020. As Teresa had already mentioned, the estimated incidence of TB in children under 15 years of age increased to almost 1.2 million. And mortality has increased compared to last year's estimates to 230,000, while the overall deaths decreased slightly from 1.5 million to 1.4 million. This means that children make up over 16% of all TB deaths, whereas they represent 12% of the burden. And 16% of child deaths are among children living with HIV. Estimates for adolescents are not yet available this year. And with more notification data available for this age group, it is hoped that more detailed age-segregated estimates can be done for the next report. So let's now zoom into data on second-line treatment initiation in children. As I said earlier, countries have reported on treatment initiation in children aged below 15 years, on second-line treatment for MDR or rifampicin-resistant TB for the first time in 2020. And the data were reported for 2018 and for 2019 to be able to report on progress against a specific UN high-level meeting target. A total of 165 countries reported at least one child started on second-line treatment in 2019. And as you can see from the table, the bottom table on the right, 6 countries, India, Russian Federation, South Africa, Ukraine, Pakistan, and Kazakhstan, reported 100 or more children started on second-line treatment. So those 6 countries cover 81% of all cases in 2019. And it can also be seen that India reported the highest number, representing over 60% of all children reported to have started on second-line treatment. The top table on the right shows that in 2019, just over 3% of all people started on second-line treatment were children. And this figure went up from 2% in 2018. And compared to the estimated annual burden as modeled by Pete Dodd and Helen Jenkins, which is the total number is 32,000 annually, just over 17% of children with drug-resistant TB were detected in 2019. This slide summarizes the cascade of care for children with drug-resistant TB. Starting from exposure to an adult or adolescent with infectious drug-resistant TB, exposed children have a high chance of getting infected with these kinds of TB. It is estimated that a total of about 2 million children have DR-TB infection. And then young children have a relatively high chance of progressing to develop TB disease after being infected. So as I said earlier, it is estimated that between 25 and 32,000 children develop drug-resistant TB disease every year. The next step in the cascade is diagnosis and then initiation of second-line treatment. And as we have seen, over 5,500 children started treatment in 2019. And this is then ideally followed by successful treatment completion. Generally, children on second-line treatment do very well, with an overall success rate of 80% reported in a large systematic review and individual patient data meta-analysis that was published in 2018. There are various gaps along this cascade of care that limit prevention and case detection of pediatric drug-resistant TB. To start, there's limited contact investigation to identify children who are exposed to drug-resistant TB that would benefit from preventive treatment if they are well, or further evaluation for drug-resistant TB disease if they have symptoms. Then, incidence estimates really rely on models that extrapolate child TB disease burden from adult TB data. Access to health services is often limited by inadequate service infrastructure, poor community awareness of child and adolescent TB, also limited integration and harmonization with general child health services, as well as risks of death without being diagnosed. Barriers to the diagnosis of MDR include the difficulties in confirming the diagnosis of MDR through bacteriological testing due to the limited number of bacilli that a child coughs up and the limited sensitivity of the tests. Specimen collection can be very challenging, especially in young children, and capacity for performing invasive collection methods is usually only available at higher levels of the health system. It is important to note that stool and nasopharyngeal aspirates have now been recommended as alternative specimens that are much less invasive for expert MTB-RIF testing. However, we also need to note that WHO recommended rapid tests access is still limited in many high burden settings. There's also limited awareness and training of health personnel, including on making a clinical diagnosis based on suggestive signs and symptoms of TB in a child with a contact with an adult with rifampicin or multi-drug resistant TB. Then, barriers to appropriate MDR TB treatment include the fact that local protocols often only allow initiation of treatment in children with confirmed drug-resistant TB. However, in children with signs and symptoms of TB who are contacts of adults with confirmed drug-resistant TB, treatment can be started based on the drug susceptibility pattern of the most likely source case. Poor access to optimal and child-friendly drug formulations and limited guidance on optimal clinical management, especially in children under the age of 6, are further barriers. Let us now have a look at how we're doing in terms of progress against the targets set at the UN General Assembly high-level meeting on TB in 2018. Countries committed to reaching 40 million people with TB with diagnosis and care, including 3.5 million children with drug-susceptible TB and 115,000 children with drug-resistant TB, as Teresa already mentioned. In the blue panel on the right, progress against the child-specific case detection targets of the high-level meeting on TB is summarized to see where we currently stand for the period between 2018 and 2022. So after two years, after 2018 and 2019, we should be at 40% of each of the targets. So for case detection overall, we have reached 30% of the 2022 target of 3.5 million. However, progress for drug-resistant TB is much worse. We are at less than 8% of the target of diagnosing and treating 115,000 children. Even though this is slightly better than we previously estimated before the data became available through global reporting, it is clear that we need to dramatically scale up our efforts on this neglected aspect of child and adolescent TB. And in this webinar, we will hear stories from the field and how different countries are implementing and scaling up actions, interventions, and research to address the existing gaps for children and adolescents with drug-resistant TB, all along the cascade of care from exposure to prevention and to diagnosis and successful treatment. I would like to acknowledge my colleagues from the WHO Global TB Program, especially Annemiek Brands, Faraima Runga, as well as the Child and Adolescent TB Working Group. Thanks very much for your attention.
So thank you very much, Sabine. I hope it was very useful information based on our latest data. More details you can find in our global TB report, and I would like to refer you to the app version of the report. You can just for 1 minute download it. It's free and it's available in 4 languages now. So now I would like to turn to our passionate doctor and with the very strong voice in favor of children and children's right, our colleague and friend Jen Furin, infectious diseases clinician working in Sentinel Project on pediatric drug-resistant TB. Jen, the floor is yours.
Great. Thank you so much, Teresa, and good morning, good afternoon, and good evening to everyone. It's really a privilege to be here speaking with you all today and to talk about this very sobering topic. I think both Ben and Sabina have shared with us some startling and concerning numbers on where we are in terms of children and drug-resistant TB. And I'm a doctor who primarily works taking care of adults and children with drug-resistant TB. So my colleagues asked me to share some examples or stories from the field and different settings where I've been working. And in trying to put the presentation together and thinking about things, I've had the privilege of working in many countries and was thinking how to put bits and pieces together, but it actually to share different challenges and stories from the field, I only had to look as far as a single family to highlight some of the issues that we all need to focus our attention and our passion to. So I want to share with you the story of one family that I worked with recently with drug-resistant tuberculosis. And it really started for a young woman when she was given a devastating diagnosis. So she's a 35-year-old woman, and she was diagnosed with rifampin-resistant tuberculosis. But this was actually not the start of her problems. Her husband had died earlier that year, and she reports that he died from coughing. The family was not able to figure out what was going on and didn't really have the funds to get to the health center for a diagnosis for him, but he died of coughing that year. And she actually lives in a household with her mother, her teenage son, and then there are 8 other children living in her household under the age of 12 years. 3 of those children are her own children, and 5 of those children are her sister's children. And her sister, she tells you, also died of pneumonia, and she's been caring for these children. So after she's given her diagnosis and started on treatment, the nurses and the doctors at the health center tell her, you need to bring all these children to the clinic because you may have given them tuberculosis. And that actually is the language that was used, very stigmatizing and very blaming, but trying to get her to bring the children in. But she can't bring the 8 children into the health center because she doesn't have transport money to get there. And she's also worried the family is deeply poor, and she's ashamed that the nurses might see that most of the children actually don't have any shoes to wear. And so she does not bring the children to the health center. But the disease has a huge and devastating impact on the family. Initially, we know the household's been suffering because of the loss of the father and the loss of an auntie. And now we have the mother who's been diagnosed with rifampin-resistant tuberculosis. But worse things are to come for this family. And this is not a unique situation. I think anyone working in drug-resistant TB knows of families like this. But the 15-year-old son starts coughing. And this young adult is eventually diagnosed with rifampin-resistant tuberculosis. He's lucky because he started on a treatment regimen with an all-oral shorter regimen. And just to point out that the majority of people globally should be treated with all-oral shorter regimens. This has been recommended by the WHO. But he has to stop taking the medication 6 months into therapy because the family is really struggling financially, and he has to try to go find work in the market. And he can't do this while he's receiving directly observed therapy. So unfortunately, he later commits suicide. And one of the reasons his mother says is because the medication turned his skin dark. It made him look a different color, sort of an orangish color. And this is a known side effect of one of the drugs we use called clofazimine. And the young woman he was supposed to marry noticed the change in his skin color, and she decided she was going to marry another man. And this was very heartbreaking for him and this important developmental stage in his life to have the diagnosis of drug-resistant TB and to be stigmatized in this way was simply too much for him to bear. 3 months after the mother is initially diagnosed, her 5-year-old son develops swelling and lumps in his neck. So she notices these and they're bothering him, but then they notice that his abdomen, his belly is starting to swell. And so she's able to take him to the clinic. The doctors there suspect that the child has tuberculosis, but because they don't get a sample and they don't do drug resistance testing, they unfortunately start him on treatment for drug susceptible TB. And unfortunately, this child died after a month of therapy. And then a year after the mom was initially diagnosed, her 3-year-old daughter is also found to have rifampin-resistant tuberculosis. She isn't growing, she isn't gaining weight, and she goes to the clinic with failure to thrive. And there the doctor does a gastric washing and finds a specimen that has rifampin resistance. So unfortunately, this young child, she started on a regimen that includes an injectable drug. And this is because the new drug, bedaquiline, is only recommended for children ages 6 years and above, and the country doesn't have access to the other new drug, delamide. So this child still gets an injectable agent, even though these drugs are no longer recommended for adults because of their dangerous side effects. This child is taken from her family and she's placed in the hospital for her entire treatment course because the country doesn't have any of the pediatric formulations of the second line drugs. And this means her medications, which are adult tablets that have to be cut and crushed and split, are deemed too complicated for her family to prepare and administer to her at home. So this family's story and deep suffering, and again, this is unfortunately not a unique situation. We know drug-resistant tuberculosis is a disease that affects families and that there are heartbreaking gaps everywhere, many of which were outlined by Sabina. Some of this comes from a deliberate exclusion of children from the public health approach. Ben outlined initially that people thought children didn't contribute to the transmission of TB and drug-resistant TB. So it's not just that children were overlooked. A decision was made to not focus on children so that people could focus on those who were more likely to be transmitting disease. So there was a deliberate decision made to exclude children. And often we approach TB as adult or pediatric TB when in fact, as this family's suffering illustrates, TB is a disease of the family and we really need a family-centered approach. Some of the challenges are that diagnosis still relies largely on sputum, although it's great news that we're making progress with stool and other samples such as nasopharyngeal aspirates. But what we continue to see as major advances are made in the field of drug-resistant TB with newer drugs and shorter regimens is that younger children are often excluded from these innovative diagnosis and therapeutic advances. They're left out of clinical trials, but people are often afraid to extrapolate good data on efficacy and safety to younger children. We have a serious gap in access to child-friendly regimens and formulations. And although the global drug facility of the Stop TB Partnership has made major advances in rolling out pediatric formulations of second-line drugs, we're still not diagnosing and treating enough children for there to be a market to keep pediatric formulation suppliers interested. And there is almost a complete absence of post-exposure management and access to preventive therapy for drug-resistant TB. This family's heartbreak is just one illustration, but none of the children in that household were offered preventive therapy for drug-resistant TB, even though there is evidence to show that preventive therapy works for TB, and it's really just the drugs that should be different for drug-resistant TB. And finally, we see that age-appropriate adherence support is utterly lacking. We talk about pediatric MDR-TB as if children across the age spectrums were one category, but we know that a 2-year-old has different needs for adherence support than a 10-year-old, than a 15-year-old. And we haven't really done our work in terms of thinking about adherence because everyone focuses too much on DOT. And we really need to come up with age-appropriate adherence support. So as we move forward in our panel discussions today and our discussions with one another, we really need to prioritize children in a human rights-based DRTB approach. We often talk a lot about how we need to include children, but we have to go beyond this. We can't simply include children. We as a TB community decided many decades ago to not include children. And so we actually have to prioritize their needs. And in order to do this, we need excellent clinical skills and tools and diagnosis, but we also need strong advocacy to undo years of systematic neglect. We have had great success with the community of practice that's on this call and with one another to demonstrate that success is possible. And COVID-19 has made addressing the needs of DRTB in children an emergency. We know diagnosis of drug-resistant TB has gone down. We know people were told to shelter in their households during COVID-19. And what this means is that household transmission of DRTB has likely increased. We keep hearing about dire predictions about how we're doing with TB this year and COVID-19, but these are not inevitable. It is not inevitable that more people die and suffer from drug-resistant TB if we act in an emergency fashion to do household management, post-exposure prophylaxis, and preventive therapy, as well as increased diagnosis for children and everyone. So thank you for this time to share the story of one family, and I look forward to hearing from the rest of the panelists about what we can do to improve the care of children affected, infected with, and sick from drug-resistant TB. Thank you.
Jennifer, thank you very much. It was really heartbreaking story, and thank you for your passionate, dedicated hard work and for the collaboration with the Global TB program. We should do much more, definitely, and tireless work should be in front of us. Let's continue and let's address all these needs and gaps as much as possible. Now we are moving to our interactive panel with voices from survivors, civil society, and countries. And I would like to start by inviting our very special youngest participant and champion, Tanmay. He is joined by his care provider, Dr. Sushant. For your information, also we have consent for his participation from his father, who is also here, Mr. Yadav. Tanmay, thank you very much for joining us. You are really our hero and champion. Your voice is very, very important for the millions of children, adolescents, and young people around the world. Please share with us your journey against drug-resistant TB, and what do you think could be done better? How we can support to other boys and girls to support, to fight, to combat this disease, because it's preventable, treatable, and curable disease. And I understand that this will be in conversation form with Dr. Sushant. Please, we're giving this opportunity to you.
Yeah, good morning to everybody. Hope we are audible now. Yeah.
Please go ahead. We can hear you very well and see.
So for the ease of communication, I will be questioning Tanmay, and then he will share his experience with you. At the outset, we would thank to WHO for giving us this opportunity, and to Tanmay to share his experiences. So Tanmay, you have to tell your experiences after you were diagnosed with TB. Okay. So how did you come to know, or what symptoms you had for which you went to the doctor initially?
First, I go to my family doctor, and he has suggested me that I go to MRI, and I have gone to MRI. In that report, he
So what problem you had, Tanmay?
MDR TB.
Okay, where did you have that problem? I mean, what you had?
In my left ankle leg.
Left ankle. So what was the problem in your left ankle?
There in my left ankle there are small pus, and he have in the left bone, in left ankle bone.
Okay, so you had pus in your left leg.
Yes.
So for how many days you are having that problem? How many days you are ill?
First 1 or 2 months.
2 months. So since 2 months you are having pus in your leg, did you have pain?
First week I have pain, then after it was not pain.
Okay, so were you able to walk, or there was any difficulty?
No, I can.
You were able to walk. So for 2 months you were having pus in your leg and swelling in your leg. So till 2 months you did not know you had TB.
No.
Okay, so after 2 months your doctor advised to do a MRI. So what happened after the MRI?
After the MRI, I have gone to biopsy.
Biopsy.
Yes.
Okay.
And in biopsy, they tell that I have TB.
Okay. Okay. So in a MRI was done, then a biopsy was done, and in the biopsy they told you that you have TB in the foot, right?
Yes.
So what happened after that?
After that, I have gone to my family doctor, and he told me to go in JJ.
Okay, so they referred, the family doctor referred you to our institute. So then you were started on medicines, right?
Yes.
Since how long you are taking medicines now?
Now 15 months became.
Yeah, for 13 to 14 months you are taking medicines now. So what kind of medicines you were taking? You had tablets or you were injections? What you had?
In first 6 months I have injection. This injection.
Kanamycin.
Yes.
Okay,
Calamine.
okay. So for how much time did you take these injections?
6 months.
So were these injections given daily or any specific days of the week?
In Sunday is no injection.
Acha, for Sunday you didn't have injections. 6 days a week you were having injection. So how did you feel when you were on treatment? What was the experience?
First I was not happy, but now I'm recovering for that time.
Okay, so now you're recovering, so you are happy. So did you take your medicines regularly?
Yes.
Well, regularly. You didn't leave your medicines at all. So did this all affect your school?
Yes, in start of 4 months, I'm not gone school because of this. Then my school teacher said that you suggested you can only go to exams, and after
Okay.
exam I have gone.
So first 4 to 5 months you were not able to attend school, but you gave your exams, right?
Yeah.
So you were taking your medications and you were giving your exams. So did you feel sad, or what did you feel when you didn't go to school, or you were happy sitting at home?
No, I was first sad.
Okay. So you wanted to go to school.
Yes.
So how did your friends react to it? I mean, did
No, they don't know that I have MDR TV.
Acha, you have not told your friends or relatives you have MDR TB. Why have you not told them?
No, I have 10 relatives, but I have not tell my friends because they will tell that don't touch him and here and there.
Okay, so you have not told your friends because you think that if they come to know, they won't they won't be with you, or they won't take you, right? So now, after your treatment is complete, do you want to tell your friends or other people that you had TB and you recovered?
No.
Acha, you still don't want to tell because you have that fear that people won't accept you. Okay, so how did your family or your doctor support you?
They support me, very motivate me, and very give me happiness to me, and very motivate me too.
Okay, good, fantastic. So, what would you suggest to all the other children or people who have tuberculosis, or what can we do to improve, diagnosis and treatment of TB in children?
I am telling them that one thing only, that they should tell their parents very fast about this thing, what they are like is paining and all.
Okay, so any symptoms which they have,
Yes.
any symptoms, yeah. So they should tell their parents and
Their parents should be immediately go to family doctor and
okay, good, and get them
and get them
investigated.
investigated.
What about treatment?
And they should fast do their treatment, and they should recover very fast.
And they should take medicines timely.
Yes.
Yeah. Wonderful. Thank you, Tanmay. I think this was a discussion. It was very fabulous. This was all about it.
Thank you very much, Tanmay, Dr. Sushant. And do you know, Tanmay, that you are so smart, so brave and handsome boy. Really, I applaud to you. So, and you will definitely become our hero and our champion. You know that we have youth movement, young people, students are, yes, you will grow up, pass your exams, and we hope to see you among young leaders. Do you want to become a doctor or not? Or you have another dream?
Thank
So
you.
anyway, whatever will be your choice, you are doing great, and you've shared very important information with us. We will definitely discuss later on how we can do better for boys and girls like you to make treatment easier. But you will succeed, no doubt. Thank you very much. Thank you. Please take care and stay safe and healthy. The best wishes to you and your family and to the doctors. Thank you very much. Bye. So now I would like We've heard a very, very important story. So probably we are not commenting, but I'm sure that we have a lot of thoughts about this story, and we should make right conclusions from it. So now it's pleasure to move to another panel of speakers from civil society and countries. And we have the question to all of them, asking them to share their country experience and perspectives on progress made to date on overcoming drug-resistant TB in children and adolescents. And what you see are critical next steps if we are to reach targets and save hundreds and thousands of young lives. And my first panelist is Blessina Kumar, our good friend and our WHO Civil Society Task Force representative, passionate advocate and leader. For Blessy, I would like to ask you to share with us civil society perspectives and experience. Blessy, please.
Blessy, we can't hear you. You need to unmute yourself, please.
Good evening. Can you hear me now?
Yes, thank you.
Thank you very much, Teresa and colleagues, for inviting me for this panel. And a big thank you to Tanmay for speaking so clearly and boldly, and for being such a champion and overcoming this. I'd also like to join Dr. Teresa in wishing you the very best in your future. So today is World Children's Day, and our children are the world's most valuable resource. And when I read this, I was thinking, of gold and diamonds and how much care we take and how much importance we give to that. And here are children who are our valuable resource and our only hope, I will say, for the future. So just to remind ourselves that we are actually speaking of a very valuable resource and a hope for tomorrow. So I'm not going to go over the facts because Sabine has very clearly told us, but just a reality check on the numbers that we are looking at, on the very little progress that we are able to make, and the big gaps that continue to exist. I want to also just draw your attention to this huge gap of children below 5 years of age that we are not able to find. And we've heard from the story earlier on that Jennifer shared of the struggles and challenges that families at the ground are going through. And I hope that, some of these stories that I will also share will inform our decisions to be more proactive, to be more quick in addressing the issues. I want to bring your attention to, stigma and some of the other challenges in children with TB before I go on to say what civil society can do. Because everything that we have done is actually reflected in this. And what we can do is also very clear for us. So we journeyed with some children from around the globe. You can see the different places from where we contacted the children, and we spoke to the children themselves if they were old enough, and to the parents to just find out what the journey is like. And this book came out in 2018. It was released at the World Lung Conference at The Hague, and we did have a young a survivor with us who became quite a star. So I want to put a face to everything that you have, heard so far. The first child that you see is 3-year-old Arena, and she and her sister, who's 2-year-old, both were sisters, children from Ukraine, and they were diagnosed with extrapulmonary MDR TB. And the mother said that they got this from the father, who had XXDR TB and was actually very, very critical. And last year, the children completed their treatment, but it has devastated the family. The children are okay, but we still are following up with them this year to see how they are doing. Next is Angelina, Angie, as we call her, from South Africa, who also had TB when she was 2 years old. And Angelina's mother is a healthcare worker, and she really struggled to give the grainy TB medications to her, and faced a lot of challenges to keep her in school, because the principal didn't want her there. But somehow she kept her at home and educated her. And I'm really glad to say that today Angie is a 12-year-old adolescent, loves horse riding and is learning the karate. She still struggles because she also has autoimmune issues, but she's enjoying life and she's a real fighter. The third child is Jackson from USA, who was diagnosed with TB when he was 3 months old. And this, delayed diagnosis really cost him his life. This child would have died if it wasn't for the mother, who really took care to, push and get the treatment that she needed. And she even was willing to move cities to get the child diagnosed and put on treatment. And the mother said that, giving crushed pills to the infant was the most difficult thing she's ever done. And then there's Osvaldo, who was barely 12 months old. He's from Mexico, and he started showing symptoms of TB meningitis. And within 3 months, suffered many seizures repeatedly. And again, Osvaldo, doctors said that would not survive, but he's a fighter. The disease left him blind and paralyzed with tubes everywhere. But today he is still continuing to fight, but not completely back to normal. Then there's, a story of two sisters, again, 13 and 9-year-old from Kyrgyzstan. We do not have permission to share their pictures. The mother was diagnosed with MDR TB first, she could not live without the children, because she was, in Kyrgyzstan, children are removed from the parents, and the children were going to be admitted in a different hospital. So she really feared and didn't want to have them diagnosed quickly. And the last journey I want to share with is actually one of, which gives me a lot of hope, of Chinmay, who is today a 25-year-old strong HIV and TB advocate. He was diagnosed with TB when he was 15 years old. And he really told us something that really hit us hard. He said, I was born and I was HIV positive. And from the time I knew, I had a lot of support. There were groups that supported my parents, who also were HIV positive. But when I was diagnosed with TB, it was a very lonely journey. I searched for support groups and I did not find any. And he struggled, he took TB treatment. And as I said, he sits on many boards. He's on the board of the Global Network of Positive People. And even in India, he's a very strong advocate. But he also said that when he had TB, there was so much of stigma. In school, he went to the toilet closed the door, and then took his medications. So these are real stories from real people. You know, we have the data, we have the numbers, but we need to look at them with a face behind so that we are actually moved and pushed to action. So what are the affected saying? The children, the carers, the parents. You know, I didn't tell anyone about my TB because I was scared that people from our community would not talk to me, would isolate me. And then there was another mother who said, I see many people around me who have TB, but they're silent about it because of fear. So, you know, this makes me think of that 65% that we are missing. So what are we doing to enable people to actually come up when they think that they might have symptoms of TB? And a 12-year-old from Kenya said, I really wish I had less medicines to take. I wish these medicines didn't have the side effects that were so hard for me to deal with. Another mother said if they had diagnosed TB earlier, Osvaldo wouldn't have suffered so many strokes and would not have gone blind. We desperately need better drugs and a shorter course of treatment. We are doing a lot better in this, but again, how long is it going to be for these newer drugs, better child-friendly formulations to reach the countries? And how much longer is it going to take for our national programs to actually start implementing this really quickly? I never had a support group for TB. You know, another child said, I had been away from school for so long that some of my classmates had forgotten me. 2 years she was out of school. And we are not actually looking at these issues. And a separation from parents. And I already mentioned about what the principal of Angie's school said. So education, not just for the people who are affected and their immediate families, but larger community is very, very important. Challenges have already been highlighted. Finding the children is very important, but it is not enough for us to keep saying we can't find them, we're not finding them. Where is the enabling environment for them to be found, for them to come forward? Diagnosis, we know that it's a challenge. We need to look at non-sputum based diagnostic tools, and I'm glad that some are actually coming up, but we need to be really quick in rolling them out. Limited availability of pediatric formulations for second line. Again, we're doing better in this, but it needs to be uptaken very quickly at the country level, and countries need to be supported to do this. And there is a reluctance to include children and pregnant women in clinical trials. This needs to change if we are committed to ensuring that children like Tanmay, children like all these others that I talked about, have a future that is healthy. And of course, we really fall short of funding for pediatric research. And the other side of it is that we have no champions for children. Nobody is championing their cause. When we look at other areas, there are champions. Why don't we have champions who are talking about children and the challenges and pushing the world leaders to do more? Lack of awareness. I just saw in this chat box, somebody had written and said that children are coming very late. They are coming late because there is no awareness for the community, what to do, what are the symptoms, when do you need to go, where do you need to go? We need to look at adherence support because that doesn't exist. We need to address malnutrition, which is a big challenge. Social support, stigma, counseling, huge challenges that we need to keep in mind. But not just challenges, every one of them can become opportunities. We need to look at an integrated approach, an intersectoral and multisectoral approach. There needs to be holistic services at the health centers, and children need to be screened for TB, especially if they're malnourished and underweight. TB preventive therapy, we need to scale it up. We need to have a child-friendly TB preventive therapy available. Nutrition centers where malnourished children are identified and provided nutrition is very, very important. School health programs exist, but TB does not feature in them. So this is an opportunity for us to really push for that. We can have clubs, children's clubs, support groups for children. And it doesn't have to be just TB affected children. It can be children who can talk about TB. Social protection, another opportunity that we need to seriously look at. And of course, community engagement, awareness, information, treatment literacy, and not just to the usual people. We need to look beyond us, like teachers, principals. Those that are in touch with children on a regular basis need to be educated about TB. Counseling services, from the story that was shared with us earlier, and from the stories that I've shared, we know that counseling plays an important role. It can make a difference between life and death. A young man committed suicide. That could have been avoided if there was counseling. And continued education. Children are missing school. What can we do to ensure that they do not miss out on classes? How can we help them continue with their education? So today, I'd really like to call on all of us to say that we owe it to our children that they have a happy, healthy future. And I'd like to wish all the children a very happy and healthy future. Thank you.
Yes, thank you very much, bless you, and thank you to all Global Coalition of TB activists you are leading for your amazing work. Can't agree more with all your requests and highlights. And of course, it's good that we have these successful stories, though they are not sometimes fully successful, but they should not be exceptions. It should be everywhere. And so, of course, we should continue our advocacy and knowledge sharing, which is essential beyond TB community. So now I would like, thank you once again, I would like to give floor to our good colleague and friend, Dr. Farhana Amanullah, pediatrician from the Hindus Hospital, Karachi, Pakistan, and chair of the Child and Adolescents TB Working Group. Please, Farhana, floor is yours.
Thank you very much. Thank you very much, Teresa, for first of all for organizing this important webinar and also for facilitating it. Thank you very much. So I, following that amazing talk by Blessy and how she brought out all the issues around pediatric TB, I would just like to sort of switch gears and go towards a little bit of data from some of our experience from Karachi in treating drug-resistant TB in children and adolescents in a programmatic manner. So this is essentially just program data, and it really highlights that even a private sector program that is run following WHO recommendations, that a lot can be achieved, and it is not all bleak for children and adolescents. So this is just to show you that the drug-resistant TB in children, as you well know, that it is not we were not even getting numbers till very recently. This is data from 2014 to 2019, and it is to highlight that we usually look classically at children up to 14 years of age. And in this, I have included data from of children 15 years and above as well, 15 to 19. So this is to highlight how the 0 to 4-year-olds with drug-resistant TB, again, over the past 6 years or so, have really not been that many. The major component is really children from who are so-called the teens, from 10 to 19 years of age. Sorry, I think my slides are a little hidden, but apologies. But this is really to show. And another very interesting finding, which is also seen, I believe, in India, is the relative, in certain programs, where that is the relative high prevalence of MDR-TB in girls. In girls, we see that in our program, and there are several factors behind it. But that is again something that is that we see in our program. So the total children in the last 6 years that have been treated in our program are 257. The important thing to note here is the high levels of severe malnutrition that were found in these children at baseline. We have Pakistan, Karachi, this particular cohort is really low HIV prevalence. Only one child is with HIV positive, which is something, as you know, that makes underlying HIV with MDR-TB, and especially if it is untreated, would result in poorer outcomes. But we do have our fair share of malnutrition. Majority of these children had pulmonary TB, and so 91%. And then we are lucky that we are able to do drug sensitivity testing. We have a gene expert who has been available for many years now. So majority of these children were bacteriologically confirmed. And since we've had LPA and drug sensitivity testing for second-line drugs, we have been actually able to see correctly and appropriately treat them when we found that they had fluoroquinolone, or they were pre-XDR or XDR. This is the photograph of a little girl who's like 2.5 years old. She was treated with the older injectable regimen. I would like to call it older now because we want to phase them out completely. So she's a 2.5-year-old who spent 2 years of her life really getting drugs for MDR-TB, which is most of her life, and 6 months of these were of daily injections. This is just to show you that there is hope and good things will happen. And this is that we are transitioning to injectable-free regimens rapidly. And in 2020, although the numbers are lower given the COVID lockdowns and whatnot, but all children were started on injectable-free regimens, and it is fantastic to see that now we don't have loss to follow-ups now, and honestly, this is the only way to go in children. And this is just to show you the outcomes. I know this is a busy slide, but the big things to point here is that the younger children did not have as good outcomes as the older ones. It was also heartening to see that adolescents were not doing so badly. They were faring okay in our cohort. So had decent and good favorable outcomes. As you can see here, 15 to 19, they were like almost 80%. Boys and girls, this is something that is very interesting. In our program that we have a lot of girls coming in being diagnosed with drug-resistant TB, but the boys seem to do worse. So they are a more vulnerable group. So basically, higher rates of bacteriologic confirmation in our program, which does kind of worry you that are we missing the really younger children because we have treated relatively lower numbers. We had higher rates of baseline malnutrition, which is again something that we deal with in our setting. Overall favorable outcomes were that we had good, decent favorable outcomes, but poor outcomes in the very young. But that I think I'm hoping will change as the program evolves and develops further. We had many more girls with drug-resistant TB, again pointing towards specific the psychosocial needs and support that this group and adolescents and children at different stages of their life need and families need. And then the transition to oral regimens from 2017 onwards, which has really been a fantastic and amazing thing for our program. So thank you very much. I think it just gives you a flavor of what drug-resistant TB can be for children and how there is a lot of room for improvement, but this is sort of a tidbit from my part of the world. Thank you very much.
Farhana, thank you very much. Thank you very much for your time. We know that you are also very busy. Many things are happening in parallel, but it's absolutely essential. It's important that you've joined us today. And you are not only sharing your experience, you're showing the example that pediatrician, of course, should continue treating and providing better diagnostic and treatment options, but you are also involved in the research, which is absolutely critical and essential to inform global guidance and provide better treatment options to more children and adolescents. Thank you very, very much, and we're happy we'll continue working together with you. So,
thank you, Teresa.
Thank you. Now I would like to give floor to other pediatrician from other high burden country, from Indonesia, Dr. Arina Triasi from the University Gajah Mada. And please, Dr. Arina Triasi, floor is yours. Share your experience with us.
Thank you, Teresa, and very good morning, good evening, and good night, my dear colleagues and friends. First, I would like to thanks for the opportunity for us from Indonesia to share our experience, which may a representative from a country with high burden of TB in general, but we have limitation experiences in managing drug-resistant TB in children. And my presentation will be more from a programmatic point of view as well of what have been done by the country for the management for child TB, in particular for drug-resistant TB. This slide is just a brief overview about the geographic and the demographic situation of Indonesia, in which we have more than 17,000 islands and also a big population with more than 250 million. These two situations actually become significant challenges in the national TB program in Indonesia, including in how to manage the drug-resistant TB. I'm going to start with an overview about what is the progress of the programmatic management of drug-resistant TB in Indonesia, which I think has so a good progression in general.
Asking them to.
Okay, sorry.
Are they responding? Are they responding?
So sorry for the interruption.
Okay, no problem. Yeah. So the PMDT Indonesia was initiated in 2009 with only 2 treatment centers at the time. And then the gene expert machine first was available in 2012 with only 8 machines. But now in 2020, we already have almost 1,000 machines, and also the treatment centers is almost 300 centers. Some laboratories also has had facilities for the DST and also LPA for the second line drugs. And the NTP also has procured some new drugs for the drug-resistant TB. However, the distribution of the diagnostic centers and also the treatment centers, because of the big archipelago nature of the geographic condition of Indonesia, made it uneven in among the provinces and among the islands, which gave a big impact of the success of the management of drug-resistant TB in Indonesia. The other activities for PMDT in Indonesia, I think similar as that in other countries, and I'm not going into detail for this slide, but this is for children. So I think it's also a problem for the TB in children in general, but actually the condition in Indonesia for TB in children in general has been getting better in terms of that we have a big attention from the NTP. But for the drug-resistant TB, this is just, I think you are all familiar with the problems, the challenges with children in the national TB program. For example, for the national guideline, the The sensitive TB, we already have our own guideline for children, but for the drug-resistant TB, it is in a part of the national guideline, and we only have a small proportion, around 20 or 25 pages of the 200 pages. Similarly, with the trainings, with a 2 days training, we only have 1 session for drug-resistant TB in children. So unfortunately, also in Indonesia, we have a limited number of trainings for specific training for drug-resistant TB in children. The child-friendly TB drugs actually has been procured by the NTP, but again, I think maybe because of the system, so the access for this drug is still difficult. Some of the pediatricians even do not understand or do not know that we have this child-friendly drugs, so it is not well distributed. In terms of the prevention for the children, we already have the recommendation for giving the TPT for child contacts. The drugs is also available from the NTP, but the implementation is not as expected. This is the situation in general for the drug resistant TB. The number of cases has been increasing very well, I think, in the last years before COVID, even though it's not as expected as the target. The number of children diagnosed with TB is also increasing from year to year, but it's still a very small proportion compared to the all drug-resistant TB cases in Indonesia. So it's around less than 1% of all cases. The enrollment is also still low, only 101 children treated since 2016. And the regimen that we use is also following the WHO guideline, first using the long-term regimen and then the short-term regimen. All oral regimen has been introduced, but has not been formally recommended in the national level. This is the treatment outcome from the 2018 cohort. The cure rate is 57. I think it's not a good one, but yeah, this is the condition. And I try to just quick analyze what is the possible problems or challenges that make the case finding and also the treatment enrollment for drug-resistant TB in children in Indonesia is still low. I think one of the problem is about the confidence and skill of the doctors to diagnose TB in children, and this is because we lack of training. So I think there is a question about, and also it's has been mentioned by Farhana, about diagnose drug-resistant TB clinically in children actually is recommended, but actually in Indonesia we still have like no confidence to treat that kind of children. So I think that's one of the problem, and we need that recommendation or guidance from the global level. Secondly, is about the role of the Child TB Working Group and also the Pediatric Association. I think it's also important for the better management of the child TB in general, and also in particular for the drug resistant, because in the last 1 or 2 years, I observed that our activities is not as good as the previous ones, and then the impact is that the drug-resistant TB is in children is the progress is not good. The other thing is about lack of resources, and one of the important thing is about the facilities to collect sputum in children. We already have training for the doctors in a remote area and also in urban area to collect sputum using the sputum induction. But the availability of the nebulizer and also the hypertonic saline and also the tube for sputum collection is still limited. So I think this is also, if we recommend to, we already have a way to collect sputum better, but then in the field it's not followed by the availability of the tools. It's also become a challenges. And then access to the child-friendly drugs, I think, is also one of the problem. So this is just an example for our children in 2016 at the time. This is from a remote area of Papua. So the doctors then already diagnosed these children with MDR TB, and then they consulted to the team in the National Committee of Pediatric TB, and then as we also have limited experience at the time, we consulted to our colleagues here, Ben, Simon, Jen, and Tony. I think thanks very much for your help. That's always have a quick response for us. But unfortunately, these children, because the doctors in that area has no confidence to initiate to give treatment to this child, then she was passed away. So this is just for a real story from the field because of the lack of confidence of the doctor. So for the way forward, I think the possibility of giving all oral regimen for children, I think it's a good thing that the doctor then is not have a concern of giving injection for 6 months for children. And in Indonesia, we already developed the revise the national guideline and will be launched soon. About the training, if I can give a suggestion for the global level, I think the global training for the pediatric TB for the management of the drug-resistant TB in children, I think it's highly needed for us, and also the Sentinel project with the book, it's very helpful for us, but then it's need for us more guidance and also the training. And the other thing, I think it's just a general suggestion for the better access and also the DSM management for drug-resistant TB in children. So that's all that I can share from Indonesia. I hope we can have more said from you all. Thank you very much.
Irina, thank you very much for your presentation and for your really hard work. And again, it's heartbreaking. It's not easy. I can imagine to see every day these stories of young children. But of course, for them, it's many times more difficult for them to suffer and to die, and for their families. Of course, and special thanks for your clear request to the global program, and the absolutely relevant and important. We will take definitely actions according to these requests. So now I would like to move to another speaker from India, a pediatrician and associated professor from the Grand Government Medical College of Mumbai, Dr. Sushant Mane. Please, again, floor is yours.
Yeah, thank you, Teresa, and thank you, WHO, for giving me this opportunity. So basically, what I'm going to do in the next 5 to 6 minutes is share the experience of drug-resistant tuberculosis in children as far as my institute is concerned, and definitely because my institute sits in a place of called Mumbai. Mumbai is already the drug-resistant capital of India. We have so much of migrants or migrants population coming here to Mumbai, that the amount of tuberculosis that we detect in this economic capital of India is huge, and out of which the number of drug resistant cases are also huge. So what we will be doing is we'll share what we do as far as our institute is concerned regarding the management of drug resistant TB in children. We have a separate clinic, we have a separate ward for catering to all these children. So what made us think about doing something for children with drug resistant TB is these alarming figures. I have quoted figures here in this chart from 2017 onwards. We started our specialty drug resistant TB clinic for our children way back in 2014. But as you see, in the last 4 years, from 2017 to 2020, the number of cases of tuberculosis which we are detecting in children are on the rise. And not only the total number of cases, but out of the total cases, the drug resistant population is going on increasing. Now it is A good sign as far as the program is concerned, the National Tuberculosis Elimination Program, because we have a robust case detection and finding protocols in place, due to which we are able to get or pick up more and more people with tuberculosis. But then, although this is a good thing that we are picking up cases, the drawback is we have so much of tuberculosis still in the community. So all this led us to think that what we could do about catering to these children. So the journey began in this institute. This is my institute, that is the Grand Medical College, Sir JJ Group of Hospitals in Mumbai, and we have been catering to people since the last 175 years. So what we were confused, or what we were thinking is, how do we go about it? How do we cater to so many children who are spread widely into this a city of Mumbai? How do we get them to our hospital and manage them effectively? And when we were all confused, what motivated us is this saying that start where you are, use what you can, do what you can. If we just keep on sitting and thinking, we are not going to do anything for our children. So we had a lot amount of brainstorming sessions with all the expert consultants in the city and also outside the city. We designed protocols. We had our national program who had given us guidelines how to go about pediatric TB. On the basis of that, we formed a policy, we formed a protocol for our hospital, that which children we need to screen, how do we need to do contact tracing, how do we take care of the community health workers, so that if one child is detected, we may go to the community workers, go to the house of the child, and get the other family members to us. Then came forming of the team. This was the team which we formed back in 2014. No job is done by one single person. We are lucky enough to have motivated doctors, nursing team, and the paramedical team who are working day in and day out for catering to children with TB. We have an in-house WHO accredited tuberculosis lab. We are able to do all the sampling, all the tests, not only the gene export of the CBNAT, but also the culture DSTs. The whole genome sequencing now is being done at our institute. Now, this was not what happened over a day or over weeks. All of us, not only the medicals but the paramedicals, have strived together to start this project in a huge hospital like JJ, and we got a good support from our national program. So the journey was not a cakewalk, and still it isn't. Even if we have a strong system in place now, we still have many hurdles which we want to overtake, and there are some mistakes which we learn from, because success is never final and failure is not fatal. We have to go on, and that what is counts. So what are the challenges? If you ask what are the challenges which we still face as far as tuberculosis in India is concerned, so there are many challenges, but solutions can be thought of. So one important challenge which everybody of us will agree here is the diagnosis of tuberculosis. We know that it is a difficult diagnosis as far as children are concerned. Sometimes the diagnosis may be incorrect or it may be delayed, and there would be a gap of many months or sometimes years actually till when the disease is diagnosed. So what we thought of is, we did a community awareness campaigns. Our national program has community awareness flyers. We have roped in celebrities, well-known people from India, who are taking the message of detecting tuberculosis right at the doorstep through various media. It could be a print media, it could be an electronic media like Facebook, WhatsApp, television, radio, everything. What we did as far as the physician and the paramedical staff was, we did a physician training. We have our own national protocol in place for detection, diagnosis, as well as management and support to care of pediatric tuberculosis. We have taken this training program not only to the pediatricians, but also to the health workers who will be working in the field, and they are the first contact to which the cases of tuberculosis would be presenting. And then referral of a child to a nodal center. We have nodal centers set up in almost every major city of India, where there is a nodal DRTB center, where everything right from the diagnosis to management, follow-up and support to care is taken off. Sample testing, there were problems or issues with the collection and dispatch. What we did was training of the paramedicals, and important thing what we need is to talk to the labs. What happens in the process is, once we send a sample, sometimes due to unprecedented conditions or sometimes due to unavoidable conditions, the reports are not traced on time. So we have a one-to-one system where we connect to our labs either via phone or WhatsApp, and the reports are shared immediately once the results are available. That decreases down, or that narrows down the delay in the fetching of reports. Next is pediatric formulations. As far as pediatric formulations are concerned, all the protocols or all the paperwork for procuring pediatric formulations is already being done, and sooner we are going to have pediatric formulations for second line drugs. As far as India is concerned, we are very happy that we are now slowly phasing out the injectable regimens for children, and we are getting the children under the domain of all oral regimens. And government policies definitely in place. We also have NGO supports which are helping us with this. Management of adverse reactions, what we have done, what system we have placed is we have our own national protocols where we have active adverse drug reaction case finding sheets where any health officer or a medical officer who is treating tuberculosis patients is given that sheet, and active monitoring or active case finding is done as far as treatment of adverse drug reactions is concerned. If there are issues with the follow-up or loss to follow-up, we have our HVs or house visitors which are provided to us by the program. If the patient does not come to follow up or misses his appointment, these house visitors actually go to the house of the patient and the patients are brought to the center. Whatever problems the patients are facing are taken care of. It is looked, the matters are looked into why the patient has missed the treatment or why the patient does not come and follow up. Along with house workers, we also have a team of counselors provided by the program which do counseling on one-to-one basis, not only to the children but also to their parents. As far as the economic burden on the families is concerned, that is the travel to your nodal center. Sometimes, if there is an adolescent child or a young child, the parents are taking care of the child, they lose their daily wages. We have an incentive approach which is given, that is the program gives certain amount of money to the family every month till the time the child is on treatment. This money can be utilized for getting good nutrition to the child, and this money is being provided right through the entire course of treatment till the child is on treatment for tuberculosis, whether it is drug sensitive or drug resistant. And as far as the other comorbidities like malnutrition, anemia or HIV is concerned, India has programs which are designed for dealing malnutrition, anemia and HIV. We have amalgamated or we have coalesced the program of tuberculosis along with these programs, and therefore all these programs run hand in hand. That means if a child with child has tuberculosis and is put on treatment, if the child has malnutrition or the child has anemia, he gets privileges under the anemia program also, under the malnutrition program also, and that is how we take care of all the other comorbidities. That's our pediatric TB facility which we are running at our center. You can see the OPD. We have a separate DRTB ward where if the patient requires admission, the child is admitted and given care. This was our first child. She was started on delamine-based regimen in 2018. She was having cervical lymph node tuberculosis. She has completed her treatment last year and she is doing quite well. So have we succeeded? So the answer is success is a continuous process. We can't say we have succeeded because we have so many challenges still to take care of. We have been doing trainings of the health and paramedical workers on a timely basis. We are very lucky to have a program in place which has contributed close to around 3 crore Indian rupees or around 30 million rupees just for the training of doctors to take care of the trainings. And the trainings are conducted now in the times of COVID. We have started online training of doctors in case finding and treating of TBs. Paramedics are no behind. We are training paramedics also. As far as community awareness is concerned, we are doing flash mobs at places like bus stations, train stations, malls, where we do a 3 to 5 minute flash mob kind of a skit or a thing where we educate the general population how to detect TB, what are the signs and symptoms, and when do they need to see a doctor. We always succeed together. Program is alone not a answer to it. We have collaborated with all the private practitioners. The public private partnership is robust, and not only the government agencies but also the private agencies are made or strengthened to take care of the case finding, case detection, and not only the case finding and case treatment but also the contact tracing. So what next? What next we look up to is we want to do more research. We want to do more give more scholarships to people who are, actually interested in taking care of TB, because research is the final way where we would come to know what are the problems faced by India, and because of which, if we get a data from the research, we would be able to formulate our protocols, our policies much better. So these are all the happy faces. What I must say, they all have completed. These are all my kids with drug-resistant TB, and they always tell us that nothing is impossible. The word itself says that I am possible. And we work as a team, as a national program and a public-private partnership. our children would be happy, and they would always be saying that I may have tuberculosis, but tuberculosis cannot have me. Thank you all for a patient listening.
So thank you very much, doctor. And it was a really very deep diving, and I like your analytic approach and vision how we can move forward. It's really great, and special thanks for your patient, young champion. So now I would like, time is running fast, and but I can't stop our excellent speakers, and for future definitely we should have more time for this webinar, because it's really very important, and all the speakers, their experience is amazing, and we are sharing very important information. So with this, I would like to give floor to our speaker, Dr. Simon Schaaf, pediatrician from the University of Stellenbosch, South Africa. Again, another high TB burden country. It will be interesting to hear from you, and if you will share with us your experience.
Yes, good afternoon, and thank you for the opportunity. Do you hear me?
Yes, yes.
Thank you. So I think in South Africa, we have been seeing a greater awareness of multi-drug resistant tuberculosis in children. And we are very grateful that we recently have developed our new South African rifampicin resistant TB guidelines, which includes both preventive therapy for child contacts of RIF resistant TB cases, as well as an all-oral treatment for MDR TB. And our National Department of Health was involved, as well as the WHO, and Jennifer Furen was also a part of this. The all-oral treatment facilitates earlier discharge from hospital, which is extremely important for us, and to get the patients back to their homes and being treated in the local healthcare facilities. We also have many ongoing studies in South Africa, which helps to improve the awareness. We have MDR TB prevalence surveys in children, especially in the Western Cape, but also MDR TB treatment outcome studies, pharmacokinetic studies, which is important for the second-line drugs, as well as for the new anti-tuberculosis drugs, which we want to use in children and also in the young children. And we also have MDR TB prevention studies in South Africa, and that helps to identify children both who have TB, but also those that need preventive therapy. Unfortunately, in the past year, the COVID epidemic, as in the rest of the world, has had a very negative influence, not only on the clinical care of patients, because they often couldn't come or didn't come to the clinics, but also on the research. So what was the effect of the COVID lockdown on the numbers? The National Institute of Communicable Diseases reported a 48% reduction in the number of tests being done overall in their labs. Our own experience at Tygerberg Hospital, which is a large referral hospital in the Western Cape, is that our bacteriologically confirmed child TB cases decreased by 50% between April and July 2020 compared to the average of children diagnosed between April and July the previous 3 years. So instead of the usual about 70 cases, we only had 35 confirmed TB cases. Nationally, according to Dr. Njeka's report, who's a national MDR TB coordinator, in the first quarter of 2019, we had more than 2,500 MDR TB cases registered, compared to the first quarter of 2020, it was only just over 1,000. So there's a huge influence of COVID initially in the beginning of the year. What we are seeing now is a sharp increase in the number of children presenting, which we are grateful for. But also many of these children are now bacteriologically confirmed, and we think that it is because in some way they present with more severe illness. So this is a slide with lots of bars. Basically, what we have done at Tygerberg Hospital in the Western Cape over the last couple of years, since 2003, is every 2 years we have a surveillance period. And the purple bars, you can see the top bars, that our number of INH and rifampicin or INH or rifampicin resistant cases varied between 12 and about 16% over the years, so it remains more or less stable. Although the MDR TB cases in the orange fluctuates up and down, it remains between about 6 and 9%. But what is disturbing is also the increase in rifampicin monoresistant cases that we can see. So basically no decline, but also no specific increase in the number of cases. What is concerning, and I saw also in Farhana's numbers from her studies, is that amongst the MDR TB cases, we have quite a high number of fluoroquinolone resistant cases. Although the number here is small, this is only for 1-2 year period. 6 out of the 27 cases had fluoroquinolone resistance, and this has important implications for both treatment and for prevention, because fluoroquinolones are often, or basically the first drug that we prefer to use in preventive therapy. Children identified with RIF-resistant TB are often the sentinel marker for RIF-resistant TB in the close community. So we have to think about the adults, but if we find a child, we have to find out where did this child get the MDR TB from. So we do reverse contact tracing. In a recent case that we admitted last week, a child with a non-resolving right middle lobe and right lower lobe pneumonia, you can see here on your left-hand side, with hilar nodes, where we knew that the father had MDR TB, so he was referred because of having contact with his father with MDR TB, and we managed him as MDR TB. But on admission, when the mother came with the child, we noticed that she was also symptomatic and not been screened for TB. And when we did her chest X-rays, she had upper lobe cavities on the left and the lower lobe opacification, and she was also confirmed to have RIF-resistant tuberculosis. And this is important for the mother, but it's also important for the staff of the hospital where the child is admitted, because it's not the child that's going to infect the staff members and other patients, but the adults who accompany the children. And I'm not saying that children don't transmit disease, they can, but in this case, with the mother being smear positive, higher likelihood that the patients coming with, or the persons coming with the child will infect the staff and the other patients. So we have many challenges and there's still much room for improvement. I think it's much better to prevent drug-resistant tuberculosis than to treat children with toxic drugs for a long period of time. For this reason, preventive therapy studies are being done in different countries, and it's ongoing. And the aim is to get a single drug regimen to manage contacts of RIF-resistant tuberculosis. At the moment, we're still, in many cases, and also in our own case, still using more than one drug for prevention. But if we can find one single drug to do this effectively, it would be much better. BCG vaccine is now 100 years old in 2021, and it's not the most effective vaccine, but we do know that it protects many children against tuberculosis, and therefore it's important to vaccinate all neonates in high risk settings or high burden settings with BCG, while we're looking for a new vaccine and studying or doing research on new vaccines. Hopefully we'll find a new vaccine that's more effective. It's important to diagnose MDR TB in children early and to start appropriate treatment as soon as possible. And for this reason, contact tracing is, in my view, extremely important. When an adult is identified, the child contact should be screened, but also if a child is found with tuberculosis, we have to find the adult source case. And when a source case is found, it's also important not only to find the source case, but to find out what is the drug susceptibility test results of the adult source case. And if there is no culture available in the child, but the child has been diagnosed with tuberculosis, the child should be managed according to the drug susceptibility test pattern of the known source case. We need more sensitive bacteriological confirmation methods, which include drug susceptibility testing. But in the meantime, we should use what we have. We have bacteriological tests, we can do cultures, we can do gene expert. Unfortunately, gene expert only currently identifies RIF resistance, and we need more than that. But there are new developments. But in the meantime, we should use what we have. We should obtain specimens from children. And if we do get a positive culture, drug susceptibility testing should be done. We still find very often in the smaller hospitals that we have a culture result which is positive, but then because of financial reasons, drug susceptibility testing is not done, and we're missing cases due to that. And further of importance is, of course, that once a culture has been sent, it should be followed up, because it takes a long time to get a culture result back, but these results should effectively be followed up. Children need to be included earlier in the study of new effective drugs. Shorter regimens for MDR-TB is already being developed for adults, and children are lagging behind because we don't have the pharmacokinetic and safety studies or safety data for new drugs in the younger children, as Jennifer also referred to. Progress is being made, however, and fortunately we have enrolled our first 2 children in the bedaquiline pharmacokinetic study, children under the age of 5. We have enrolled 4 children in the clofazimine PK study, and clofazimine is an old drug, but we still don't have pharmacokinetic data on clofazimine in children. So these studies need to be done, and these studies need to be done effectively and as soon as possible. Further, a 6 months shorter regimen for MDR-TB in children is under development. It's called Smart Kids, so keep your eyes open for this. It's called also Impact 2020. Most important, and finally, healthcare workers, clinicians, and nursing staff, or whoever is working with children with tuberculosis, should always consider the possibility that a child that they treat may have drug-resistant tuberculosis. If we don't think about it, we will not diagnose it. And I think it's important that we keep our eyes open and that we keep being alert and aware of MDR-TB. Thank you very much. Sorry, I'm done and I don't hear.
So, sorry, once again, I would like to thank you, Dr. Schaffer, for your excellent presentation and for highlighting very important points. And special thanks for sharing information on the impact of the COVID on TB services. And we are deeply concerned that with the sharp drop in TB notification, and we can see, of course, in South Africa, we are monitoring on monthly basis, and in many other high burden countries. And we've seen also in the presentation made by Dr. Banet that he had some concerns about the growing the notification of the cases of children with drug-resistant TB. Of course, from one side, it could be concerning, but taking into consideration huge gaps and numbers of missing people, we should take it, I think, positively, that we are improving notification, of course, and we should close these gaps in the diagnosis and care. So I would like once again to thank all our excellent panelist speakers, our champions and civil society activists for this very important dialogue, for the important requests and sharing your excellent experience. So we are running out of time a little bit, but I think that we should still look at our questions and try to provide some answers. And I would like to facilitate this quick session. My colleague, Monica Diaz, please.
Thank you, Teresa. So many thanks for all the questions that have been flowing in. And we invite the attendees, if you have more questions, to please put them down in the Q&A function. We will, panelists have been responding to some already, but we have the opportunity to take a few live. So to start with, we'd like to take the question from Dr. Jeffrey Stark from the US. He says, and this is addressed to all panelists, given the difficulty of microbiologically confirming TB, not to mention drug-resistant TB in children, especially beyond rifampicin resistance with expert, how can we address MDR TB in children without more contact tracing? How is WHO emphasizing the need for contact tracing in locations where MDR TB in adults is occurring? So to address this question, I'd like to start by inviting my colleague Sabina. If you could start with your response, and then I will turn to Dr. Ben Murray and Dr. Jen Furen. Sabina, the floor is yours.
Thanks very much. Thanks very much, Jeff, also for that very important question. And of course, we know that WHO has been recommending a contact investigation for years now, but we are dealing with a huge policy practice gap that has, for example, also been described in a lot of detail in the 2018 roadmap towards ending TB in children and adolescents. And at WHO, we regard contact investigation as one of the critical interventions to reduce the both the case detection gap as well as the prevention gap, linking contact investigation to further evaluation for children who are symptomatic, whether they are exposed to drug-sensitive TB patients or with to people with drug-resistant TB. And if they are not symptomatic, they would be eligible for preventive treatment. We're also trying to explore different models of care in terms of what are the best ways of actually conducting contact investigation, how can we involve communities, how can we make sure that this is a process that is done in the most active way to really find these children and manage them appropriately. Of course, in terms of prevention, as Simon has highlighted, that is recommended, but we don't have a lot of detail on what to give, and so we are waiting trial data to inform that further. Other important things, of course, are looking at people-centered care, patient-centered care, as well as harmonizing and integrating with other services. But perhaps I can hand over to Ben and Jen to provide their perspective as well. Thank you.
Thank you, Sabina, and thanks, Jeff. I'll leave the preventive therapy comments to Jen because she's very passionate about it with good reason. Just to touch on the diagnostic access that you referred to, I think we have to emphasize that Expert Ultra is a great advance for children, and we should have Expert Ultra available in all settings where TB is endemic. In many countries, children still have restricted access to Expert or Ultra, and it's often not available for extrapulmonary tissue types, so only sputum. And we know that in children, often the specimens are not sputum. So many countries are still restricting access to Expert and Expert Ultra, which is our first line of detection for children. Obviously, we need access to culture wherever that's available, but that's unfortunately not the case in many settings. Just to mention about the Expert XDR, cartridge that's coming along that would fill the gap of at least detecting quinolone resistance and resistance to some of injectables. Unfortunately, we're no longer going to use, or not unfortunately, we're luckily no longer going to use injectables. So the expert XDR cartridge is a bit outdated by the time it will be made available, but at least for the quinolone resistance, it should be provide a rapid test in most settings. In settings where nothing more than an expert or even a clinical diagnosis is available, just to emphasize, the WHO has a recommendation that a child should be treated according to the drug resistance pattern of the most likely source case. If the mother has MDR-TB, please treat the baby for MDR-TB if the child has TB. And in settings where there may not be a known source case, and if there's standard programmatic management of MDR-TB, so if, let's say, expert positive, we don't know about drug resistance pattern beyond rifampicin, then that programmatic management should be applied to the child as well. And we would expect that programmatic management treatment to be based on the most recent drug resistance prevalence survey that's been done in the country, to give the child the best possible chance of an effective treatment in the absence of good diagnostics. But I'll hand over to Jen to talk about preventive therapy.
Yeah, I'm cognizant of the time, but I just wanted to say, this webinar has been wonderful, but I think what we need to do is come out of it with some very concrete action steps. And I think the questions about contact tracing and preventive therapy are an ideal place for us to say, these are no longer sort of, oh, do it if you can, or you have time, or to meet the targets. In the setting of COVID-19, where we know diagnosis of drug-resistant TB went down, and we know people were told to shelter at home, we are absolutely facing an emergency of household transmission of TB and drug-resistant TB. And contact tracing, treatment of infection, post-exposure management are now emergency interventions, right? And this is to mitigate the impact of COVID-19 on TB. It's not enough for us to do our modeling studies and wring our hands and say, oh, this is going to be really bad for TB. We actually now have the opportunity to respond in an emergency fashion by urgently implementing household contact tracing and giving preventive therapy or treatment of infection to people that we know have been exposed to TB and drug-resistant TB in the households. We know the studies are great and the trials are great, but those have also been delayed now by COVID-19, and we can't afford to just sit back and wait for another 5 years. It is an absolute emergency for us as a TB community to come out very strongly in favor and support of household contact tracing and preventive therapy or treatment of infection as emergency COVID mitigation efforts. And we have the know-how to do it. We've seen the infrastructure that's been built for COVID-19, and we can utilize that. This is really an opportunity for us as a TB community to sort of leap ahead and really shine in this area. Thank you.
Thanks so much, Sabina, Ben, and Jen. So we just have time for maybe one or two more questions, but now coming to another question, but which is very relevant to these times and building on what Jen said, how do we, this is from Saiza Orkilas, how do we address the stigma of getting tagged as COVID whenever one gets checked for cough? That is currently the fears that Saiza says they have assessed from people in communities here, rural and urban alike. So for this response, I'd like to first call upon Blessy and then invite other panelists to comment as well.
Thank you, Monica, and thank you for that question. I did put some points in the chat box. See, stigma is stigma, whether it is TB or COVID. And what we are seeing is that we've done a better job with addressing COVID stigma. The only fear is that, you may not get the treatment, you may not get the right support in terms of, like in India, we're struggling for beds in ICU and things like that. But actually, social and individual stigma is very less. People are coming forward themselves, sending WhatsApp messages saying, I've been, tested positive for COVID. I'm isolating myself just to let everyone know. Leaders are doing, everybody's doing it. But what I want to say is that stigma reduction strategies have to become part of our national plans. They have to be, strategies to implement ending stigma into our programs, and they should be given as much importance as everything else in the treatment and care package that is offered to individuals. Just to cite an example from India, we have been working with the National TB program for the past 6 to 8 months to put a national end TB stigma strategy together. And the national program has really taken an ownership of this. We are supporting them, but they are the ones who are actually going forward with this. And before the end of the year, they will announce that. And I think that will be a good example for us to follow. So we cannot push stigma to the back burner. It is a huge barrier. We can have the best tools, the best treatment, but if stigma is hindering people access that, then we've really failed even before we've started. Thank you.
Thanks so much, Blessy. Very key and clear response. So now we'd like to take one last question, and this comes from Maureen Sikade. Also, thanks to all the attendees who've raised various questions. Some have been answered. There have been epidemiological questions and others. So we'll take this last one, and feel free to reach out to us via email for more responses. So this one from Maureen is again is focused on capacity building. How do we expand drug-resistant TB-focused capacity building, especially on case finding, beyond the clinicians providing drug-resistant TB care? The children or adolescents with or at risk of TB commonly present to clinicians who do not provide the specialized care, and this probably contributes to diagnostic delays. So perhaps we could start with the country panelists, if you would like to take this and respond. I don't know if Sushant is still connected, or Rina or Simon. Would you like to respond on this?
Yeah, let me try. I'm Simon.
Thank you, Simon. Please go ahead.
Yeah, I think it takes a long time to make people aware of MDR-TB. I mean, we started in South Africa already in 1994, when it was said that MDR-TB doesn't exist in children. And it takes a long time to make even doctors and healthcare workers aware of MDR-TB. I think there are many ways to do that. MDR-TB needs to be built into guidelines, as we have seen with Indonesia and other countries. Ethiopia has a lot of emphasis now also on MDR-TB, and I think that is one way of doing it. Training, of course, and not only at the level of the doctors, but in my view, it's important that training of MDR-TB and drug-resistant TB should start at pre-graduate level. So with doctors being trained and nursing staff being trained, making them aware of the resistant tuberculosis forms and what to do in those cases. Blessy and the team and all the people that work with people in the community, I think it's extremely important that they make the community aware of, firstly, the fact that people can have TB, and they can have, of course, COVID and TB. So I think, and and in South Africa is often, of course, a question of HIV and tuberculosis, also with a lot of stigma to it. And make communities aware of TB in the first place, but also the fact that TB can become resistant to the drugs that we normally use. And they should also understand, because the patients often do not understand what MDR or drug-resistant TB is. They don't understand why should we take longer treatment than the others. Some take 6 months and some have to take 18 months. And I think all of that needs attention. So it's a wide scope. It's not only at medical level, but I think at the medical level is where we should start, but it should also go into the community.
Thank you, Simon. Absolutely. And I think other colleagues have also added, I think, online about this, the need also, not just medical, but also with communities. I see, Rina, that you've connected, and after you, Rina, maybe Sabina, very quick responses, and then we can close.
Okay, thank you, Monica. I think I agree of what has been answered by Jen, but in addition of that, I think it's important for us to, it's not only about the drug-resistant TB, but the awareness about the TB itself. So it is not about the clinician who are not familiar with drug-resistant TB can diagnose, but just recognize and then refer to the appropriate level of care. And for that, I think it's also important for us to also thinking about our curricula in the medical school. It's not only because when medical students were trained, usually they are trained in good facilities, but thinking about a situation combining upon the condition of the children and the risk of having drug-resistant TB, that it is not always that we have to make a diagnosis based on the sophisticated tools. It's It's a very more likely to be found by the medical students when they work in the field. I think it's also very important. So I think the emphasis of this thing will increase the awareness and also the early detection of TB in particular, not only the drug-resistant TB in children. Thank you.
Thank you very much, Rina. Great response. Over to Sabine.
Thanks very much. I just wanted to add a few thoughts. I think a lot of issues have been raised. Just a few thoughts on the programmatic level. I think one way of also coordinating all these responses is through the technical working groups that exist in many countries that often include other programs. So it could address some of the issues around harmonization and integration. And also in many countries, the pediatric associations or societies are active in those technical working groups as well. And that could be a very valuable addition as well. Thank you.
Thank you very much, Sabina. And so that's all from our Q&A. But as I said, please do reach out to us, and you've seen our colleagues here. We will be happy to come back to you and respond. Just to add that all the presentations will be available and the recording as well on our WHO website, and I put the link in the chat. So do check out our website. I now turn over to Dr. Teresa Kasayeva to close.
So thank you very much, Monica. Thank you very much, dear colleagues, our distinguished panelists, and all who connected. We can see more than 120 people connected. And it clearly shows that we should continue with these webinars, and we have such plans on a regular basis. It gives us excellent opportunity to expand audience. Probably we should involve also not traditional audience, but beyond. We should go beyond TB community, definitely. And so we can see even during the pandemic, we can somehow use our challenges and transform them into the opportunities. And we will definitely continue. We will carefully, once again, collect and review all your proposals, ideas. I've heard many important points highlighted, and of course we will take them into consideration and hope we'll come back with some follow-up actions and proposals, and many very important points. Just one of them highlighted by Irina, related to the medical students. Indeed, even in this very specific audience, which should be aware, we unfortunately can't see this high level of awareness. And we've conducted recently, when I visited one of the high-burden countries, we had a meeting with the students. We've conducted quick survey with them and asked very simple, basic questions about TB, and we were really surprised that the awareness was among medical students very low. So it shows that we should do much more in different areas, in knowledge sharing, in providing access to the essential services, in protecting these services from disruption during different pandemics. And of course, we should learn the lessons from the COVID. We are not competing, of course. All lives are important, and we should try to do our best. But we are comparing the approaches. For example, it takes for a long time to adapt and implement guidelines, and even our latest guidelines are not so proactively adaptable, despite the fact that they are giving much better options for our children and for other patients. And now COVID recommendations are immediately uptaken. So, and this should be somehow analyzed. Of course, we should, this emergency approach, I would support Jennifer's idea, should be undertaken. The same with the funding. We are chronically underfunded, including research, and especially related to the children and adolescents with TB. And now we can see that investments can come very fast and massively, and we can't continue using these 100-year-old vaccines and other outdated tools. So let's learn, let's try to do our best, let's strengthen our advocacy, and important thing to be joined, to be unanimous in our messaging. And of course, we will succeed, because we have no another chance. We should do our best for those struggling, and still, especially children, I mean, dying from TB. You can see this flower in front of me, and probably you're wondering why it's here. It's this flower was made by one of the young children from TB hospital, and given to us during Moscow Ministerial Conference. They requested us to do our best for children, and we are keeping in front of us as a reminder that we should do better for our children, because we should leave world free of TB for them. So, and with this, I would like to close our webinar, and we'll be happy to see you again next time. Please stay safe and healthy.
Thank you, everyone. Bye-bye.
Thank you.
Thank you, everyone.